Hello, good afternoon and welcome. So nice to see everyone today. I am Jamie Seward, Associate Director of Affinity Engagement Programs with the Johns Hopkins Office of Alumni Relations. Before we proceed, I'd like to acknowledge our co-sponsors, the Department of Neurology and Brain Sciences, and the Healthcare Affinity. Now, before I turn the program over to our moderator and our speaker, I encourage you to ask questions by typing them in the Zoom Q&A at the bottom of your screen. Now, it is my pleasure to turn the program over to our moderator and my friend and colleague, Rachel Ermer, Assistant Director of Development with the Department of Neurology and Brain Sciences. Rachel?
Thank you, Jamie. Thank you to everyone for tuning in today. And thank you to Dr. Deanna Saylor for joining us from many time zones away. We appreciate you being here. Dr. Saylor is a neuroinfectious diseases and neuroimmunology specialist with special interest in the neurological complications of HIV infection. Her clinical interests also include other infectious and inflammatory diseases of the brain and spinal cord, including multiple sclerosis, transverse myelitis, and encephalitis. Dr. Saylor also specializes in global health and neurology, and her research interests include better understanding the neurologic disease burden in resource-limited settings, improving neurological education of both neurologists and non-neurologists in resource-limited settings, and improving the care of patients with neurological disorders across the globe. She has ongoing research collaborations in Uganda and Zambia and has previously lived and worked in Kenya. Most recently, Dr. Saylor and her family moved to Zambia in 2018, where she developed and continues to lead the first neurology training program and the first inpatient neurology service in that country. She will share more about this work with us today. So with that, I will turn the program over to you, Dr. Saylor.
Thank you so much, Rachel, and thank you to everyone for taking time out of your afternoon to join us today. It's my pleasure to be joining you from Lusaka, Zambia, and sharing about our work developing neurological care and training in Zambia. Before I get into the specifics of the work we're doing in Zambia, though, I think it's first important just to make sure we're all on the same page about the importance of global neurology. So the Global Burden of Disease study in 2016 showed that neurological diseases are the leading cause of disability and the second leading cause of mortality worldwide. But this burden is not distributed equally. So 75% of the global burden of neurological disease is in low and middle income countries. And these are the same countries that have the smallest neurological workforce to care for these patients. Oops, sorry. I like this quote from the WHO Atlas of Country Resources for Neurological Disorders. It said, there is a growing recognition that the burden of neurological disorders is disproportionately high in low and middle income countries where healthcare services and resources are often scarce. Importantly, the neurological burden of disease is expected to grow exponentially in the next decade with the highest burden in low and middle income countries. So this burden is already disproportionately affecting the world's poorest countries, and that situation is only going to worsen in the coming years. And what we also know is that the number of neurologists simply does not match the burden of neurological disease. So if we look at this graph here, this shows the average number of neurologists per 100,000 people in the population by country income strata. So you can see that in high income countries like the US, there's about 5 neurologists for every 100,000 people. When you look at lower middle income countries, that ratio drops to 0.13 neurologists for every 100,000 people. And in low income countries, it drops even further to 0.03 neurologists for every 100,000 people. If we look instead by world region, you can see that Europe is the best off of all world regions with about 6.5 neurologists for every 100,000 people. And Africa has the fewest neurologists per capita in the world at 0.04 per 100,000 people. In the US, that number is a little more than 5 for every 100,000 people. And in Zambia, where I'm based, that number is 0.02 per every 100,000 people. In addition, there are few neurology training programs in many low and middle income countries, and this is especially true in sub-Saharan Africa. So on this map, countries in blue have at least one neurology training program in the country. Countries in pink don't have any, and countries in white, there were no data available, so probably also don't have any. And so when you look at Africa, you can see that there are very few neurology training programs on the continent, so very few opportunities to reverse this trend of not having enough neurologists. So when we moved to Zambia, one of the first things that I wanted to do was figure out what kind of neurological diseases that we would be taking care of and that I should be training people to take care of. And so we set out to define the epidemiology of neurological disease. And this was really done and wouldn't have been possible without the help of Aparna Nutaki, who was then a second-year medical student at Rush University and is now a graduating medical student going into neurology. And she spent a year and a half working with me. And during that time, she helped us to develop a comprehensive clinical registry of all the patients admitted to our neurology inpatient service. We captured information about the symptoms that they presented with, their exam findings, the results of testing that we did, in our final diagnosis. And we captured data over the first 6 months of the neurology training program that we developed. And what we saw was that our neurology service was incredibly busy. So in 6 months, we cared for about 750 patients, or about 125 per month, which is astronomical compared to what most US neurology services will see. And in that, we saw we had two very different populations. So almost half of our patients were admitted with stroke, about 43%, and then 57% had other neurological conditions. And you can see that our patients with stroke, as expected, were older, with an average age of 60 compared to 42 on the non-stroke side. But we also saw that our stroke patients were disproportionately female, almost 2/3. And about 2/3 of our non-stroke patients were men, actually. And that we had a lot of poorly controlled HIV infections admitted to our service in the non-stroke side. So about a quarter of our patients with non-stroke disorders were people living with HIV who had poorly controlled infection. And then if you look down here, you can see our mortality rate, which is very, very high. So 17% of those admitted with non-stroke conditions died in the hospital, and almost a quarter of our stroke patients died in the hospital. When we look further at the types of conditions that we were caring for, you can see that a little over half of the patients with non-stroke disorders presented with seizures. About a third of those had infections. And then we had a smattering of all of the other neurological disorders that you would see in any setting. When we look closer at our stroke patients, we broke our stroke patients down by subtype. And so there's two different kinds of stroke. There's ischemic stroke, where you have a clot that prevents blood from getting to part of the brain. And there are hemorrhagic strokes, where you have a blood vessel rupture and bleeding into the brain. And in the US and most high-income countries, ischemic strokes, where there's a clot, account for 85 to 90% of strokes. And hemorrhagic strokes account for 10 to 15% of strokes. And that's important because even in a well-resourced setting like the US, people with hemorrhagic strokes have a much higher mortality than people with ischemic strokes. But you can see here that our distribution was quite different. So ischemic strokes accounted for a little over half of our strokes, whereas hemorrhagic strokes accounted for almost a third. And then we had this 15% or so of what we called unknown strokes. So these were patients who were admitted with a suspected stroke and either died before they could get a CT scan or were never able to get a CT scan. So neuroimaging in our setting is quite a challenge. Sometimes, like now, our CT scanner is broken and we can't get anyone's CT scans. Sometimes patients have to pay for a CT scan before they're able to get it. So it may take patients 5, 6, or 7 days to raise the money to be able to pay for a CT scan, or they may never raise that money and we may never actually get the CT scan to confirm what we think is happening. So that's what we mean by this unknown stroke. And again, when you look at the mortality, our mortality is higher than what you would expect in high-income countries, but the proportional representation of patients with hemorrhagic stroke having a much higher mortality than ischemic strokes is similar to what you would see in a high-income setting. So not only do we have a huge burden of stroke, but we also have more severe and more dangerous strokes, but yet we have fewer resources with which to try to manage these patients. So I think just stepping back, how did we go about developing neurological care in Zambia? And I think to start with, I just want to orient everyone to Zambia. So Zambia is this country here in dark red. It's in South Central Africa, and it's a country of about 18 million people, of whom 3/4 live on less than $1 a day. And at the hospital where I'm working, about 85% of our patients that we serve live on less than $1 a day. HIV prevalence in Zambia is almost 12%. So if you just let that sink in, that means that about 1 out of every 8 people that you meet on the street has HIV. This is the 7th highest prevalence, HIV prevalence in the world. And in addition to HIV, Zambia is also one of the 30 high TB burden countries in the world. And to deal with both of these epidemics, as well as now COVID and all of the non-communicable diseases like stroke that are happening in larger numbers, it has about 1/3 the recommended number of doctors. And so when I arrived in 2018, the entirety of neurological care was provided by 3 other expatriate neurologists. I made number 4. And the other 3 were predominantly doing research. So they each held a half-day outpatient neurology clinic where they saw patients with neurological disorders, but there was really no inpatient neurology care at all. So patients that needed to be admitted who had neurological problems were admitted to a general internal medicine service and cared for by general internists. So we set about starting the first ever neurology inpatient service in Zambia, and we were doing this at the University Teaching Hospital. So this is the largest hospital in Zambia. As a point of reference, if we compare the size, the main campus at Johns Hopkins has 1,154 beds. The UTH, or the University Teaching Hospital, has 1,655 official beds. So it's quite a massive hospital. And I say official beds because this doesn't count patients that may be in the hallways or in the aisles or sharing a bed when things are really packed. So usually we have even more patients than that in the hospital. UTH does serve as the national referral hospital for Zambia. So our catchment area is Lusaka, which is the capital of Zambia, a city of about 3 million people. But we also see patients referred in from hospitals from all over the country. It's also the primary teaching hospital in Zambia, and the majority of postgraduate training or residency training takes place at this hospital. And again, when I arrived, there was no inpatient neurology service here or anywhere else in the country. But yet we had the resources to begin a neurology service. So there are 2 CT scanners on our campus. Usually at least one of them is functioning. Like I mentioned, this week we've had particular problems in that neither of them are functioning. We do have an MRI scanner. Again, the maintenance can be a problem. So there was a 6-month period a couple of years ago where it was down waiting for maintenance from another country for some time. So it tends to come and go, but usually we have access to MRI. We do have our own EEG lab, and we have an EMG and nerve conduction studies lab, and then we are able to do lumbar puncture. Although we don't have the lumbar puncture kits that we use in the US, we actually perform them using IV cannulas to obtain the spinal fluid. So we arrived in January of 2018, and in May of 2018, we started the inpatient neurology service. And so initially we began with a couple of internal medicine residents and myself starting to see all of the patients with neurological disorders. And at first, people thought we wouldn't have many patients, but it turned out once we started putting all of the patients with neurological disorders under the care of the same team, we actually found that we were either the busiest or second busiest service on the internal medicine wards. We sort of run neck and neck with the infectious disease service. So we do have quite a high burden, and we see a lot of patients. Just to give you some visuals of where we work. So this is a picture of the internal medicine wards at UTH. So you can see that there are 3 stories here, and each one of these long corridors is actually one big ward. It's a big open ward with multiple beds. So you can see here, here's a picture of a ward. So there's sort of beds lined up around the walls. There's often beds here in the middle in the aisle. We have curtains that we can pull down to try to provide some privacy, but you can imagine that in this type of setup, it is difficult to maintain patient privacy as you're having sometimes very personal and private discussions, obviously. You'll also notice that most of the patients have someone sitting next to their bed. So these are called bedsiders or bedside caregivers, and these are a family member or friend who basically sits next to the patient 24 hours a day and helps to care for them. Just like there are physician shortages, there are nursing shortages. So a lot of what we would consider to be nursing care, things like bathing the patient, toileting the patient, feeding the patient, there's not enough nurses in the ward to do that for all the patients. And so those sorts of care really fall onto the family. And I think one of the most remarkable things is that 99% of patients in the hospital have a family member at their bedside 24 hours a day who's able to help provide that care. Here's a picture of us on a typical day on rounds. So we often, at least pre-COVID, had visiting neurology residents from various institutions in the US. We have medical students rounding with us. We have internal medicine residents rounding with us, and then our neurology residents as well. There are obviously many challenges. So especially before we had graduates of our neurology training program, it could be sort of an isolating feeling being the only neurologist and not really having a lot of colleagues to talk through difficult cases with. Our diagnostics are quite limited. Our therapeutics are quite limited. And so there are obviously a lot of barriers to providing the type of care that you may want to provide. But with a good neurological exam and clinical reasoning, we can still help a lot of patients. But the challenges are many. There was even a day when the ceiling literally fell on our heads as we were rounding. So there are always unexpected challenges as well. And so there are definitely days when we just feel like we don't have the right tools for the situation. And some days you even end up fighting an ostrich with a plastic chair. A year, but because we've developed neurological training. So I think just to start with, again, kind of framing why I think it's important to train people in their home countries is that we're going to be training people based on the most common disorders that they're going to see in that setting. So obviously the epidemiology, the spectrum of disorders that I'm taking care of here in Zambia is quite different than the spectrum that I care for when I'm the attending physician on the inpatient neurology service at Hopkins. And so when you send people out of the country, they end up learning how to take really good care of patients with a completely different set of disorders than what they're going to see when they return to their home country. So training them in country allows them to train on the disorders that they're most likely to see, and also with the resource availability in that setting. So again, if you send someone to a high income country where they have all of the diagnostics and therapeutics available to them, it's great that they learn that, but then you really have to change your practice when you come back to a resource limited setting. And then obviously training people in their home country lowers the likelihood of brain drain or the likelihood that they may not return and practice in their home country. So with this in mind, in October of 2018, we started the first ever neurology training program in Zambia. So these were our first 5 trainees. The 2 women in black in the middle here, in Fama Kawatu and Lisa Nkole, they were our first pediatric neurology trainees. And then the other 3 here, Stanley Zimba, Lorraine Chishimba, and Mashina Chamba, were our first adult neurology trainees. And I think just as I was developing the curriculum for this new neurology training program, there were a lot of opportunities. I was designing the first ever neurology training program in Zambia. There had never been a training program there, and so there were really no preconceived notions about what neurology training was supposed to be like. So I got to think about what were the parts of my training that I really liked, what would I wish would have been different, and try to develop a program that matched that. was also able to blend the strengths of traditional Zambian postgraduate training with the strengths of traditional US postgraduate training. So postgraduate training or residency training in Zambia is actually considered a master's degree program. So I had to design formal courses. There had to be exams as part of this. And as a result of it being a master's degree program, there tends to be a heavy didactic emphasis on lectures and learning from books. And as a result, the trainees really get a lot of protected time to go to these learning conferences, which I did really like. But there sometimes is less of an emphasis on the clinical bedside teaching. And that was something that I really valued in my training at Hopkins. And so I was able to combine the trying to have a strong didactic curriculum with really making sure we were emphasizing the bedside teaching and clinical care and clinical reasoning components of training as well. The structure of our training program is a little bit different than what you would see in the US as well. So in the US, neurologists, they spend 1 year doing internal medicine and then 3 years doing neurology training. So a total of 4 years of residency. In Zambia, it follows a slightly different a schedule. It's really part of the British system. And in the British system, neurology is still considered a subspecialty of internal medicine. And so internal medicine training in Zambia is 4 years. So our neurology training ends up being 3 years of internal medicine and then 2 years of neurology training. The other thing that I was really, really cognizant of as I was creating the curriculum for this program was that we were really developing an entirely new field of medicine within Zambia. There was really no data on what kinds of neurological diseases were most prevalent or the outcomes or the best way to care for these disorders within the setting that we had and the resource constraints that we had. And so I really wanted to intentionally create an academic and research focus within our program. I wanted our graduates to have the skills and the interest, hopefully, in really pursuing research to generate locally contextualized and locally relevant data that could then inform how neurological care developed in Zambia and could be used to advocate to the Ministry of Health and other policymakers to make sure that the resources that we had would improve. And so in doing this, I developed a weekly journal club where we review scientific articles and critically appraise their strengths and weaknesses and whether or not the results apply to our own practice. We also have a weekly research methods seminar where we go through aspects of how to complete clinical research. And then we really encourage scholarly activity amongst our trainees and our graduates. And our trainees have really embraced this challenge and have been incredibly skilled and successful in their endeavors. And so just in the first 4 years, we've had trainees that have presented multiple oral and poster presentations at scientific conferences all over the world. So they have presented at national conferences in Zambia and won awards at these conferences. They've presented at regional conferences like the Neurological Association of South Africa, and they've presented at international conferences like the World Congress of Neurology, the American Academy of Neurology, and the American Neurological Association annual meetings. You can see here, this is Stanley Zimba presenting at one of the American Academy of Neurology annual meetings. And then I think the other opportunity that I did not anticipate, but might actually be the greatest impact of our program, is what I often call the spillover effect. And what I mean by that is just by having neurologists at the hospital, by having a neurology service that the medical students rotate on and the internal medicine residents rotate on, we have increased the exposure of all healthcare workers at the hospital to neurology. And so we have seen a huge improvement in the level of general neurology knowledge from non-neurologists at the hospital. So the internal medicine residents are now much more comfortable assessing patients with neurological disorders and managing patients with neurological disorders. The medical students are getting much greater exposure to neurology and how to approach these patients. And while I'm obviously really passionate about training neurologists, and I think that's a really important thing to do, if we step back and just look at sort of the public health benefits of training neurologists, we're training somewhere between 1, 2, 3, 5 neurologists a year. And at that rate, it's going to take decades to reach the number of neurologists that would be needed to provide adequate care for all of the patients with neurological disorders in Zambia. However, if we are also improving the basic neurological knowledge of every graduating medical student and every graduating internal medicine resident, then that means that the majority of patients that have, common neurological disorders are going to receive better care from their non-neurologist provider because we've increased the general level of neurology knowledge. And so I think this has been a really important consequence of having our program in place. So probably the proudest day of my professional life was about a year ago when our first group of trainees graduated. And it was an incredibly emotional and proud day, mostly because these are 6 of the most talented clinical neurologists, the most motivated and dedicated trainees that I've ever worked with. And they've already changed the face of neurology in Zambia and are going to continue to really move the field forward, not just within Zambia, but within the region as well. And we're still growing. So this is a program planning meeting that we had at a coffee shop a few weeks ago. And you can see that we have some of our graduates, but we also continue to have new trainees. So in the blue shirt here is Dr. Moses Mata, who will be graduating as our next neurologist next month. I have Dr. Frighten Mutete and his co-trainee, Dr. Nalucha Mwendaweli, will be graduating a year from now. We have 3 more trainees that will graduate the year after that, 2 more the year after that. And so we really have a good pipeline of future neurologists coming through the training program. And it's also been a really proud moment to watch our graduates all take increasing roles in leading the program, leading the teaching, leading the rounds. And so it's certainly been a nice change for me to have colleagues that are, available to discuss complicated cases with and are really taking an active role in leading the inpatient service and the teaching of our trainees. So we've accomplished a lot in 4 years, but we have a lot more that we'd like to accomplish and we're excited about as well. So as far as clinical innovations are concerned, we actually launched a teleneurology service during the COVID-19 pandemic here as well. So many of you have probably experienced telemedicine in the US during COVID-19. We launched a similar service, except that our patients don't have access to the internet or Zoom, and we didn't have a fancy platform with which to provide this service at our hospital. So we essentially made sure that we called our patients and had telephone calls and were able to make plans for them to continue to get prescriptions or tests ordered or whatever they needed, because our clinic was actually completely closed during several months of COVID-19 peaks in Zambia. So this was a really great way for us to ensure our patients didn't fall through the cracks. And we actually learned that some of our patients preferred this because they didn't have to pay for transportation from their far-flung villages to come into Lusaka. They didn't have to miss a day of work. Oftentimes, our patients are paid, a daily wage for the work they do that day. And so coming to clinic and traveling several hours in either direction, not only is the transport cost, but also the lost wages for that day. And so this is actually something we're continuing to offer to some of our stable patients who live far away is telephone check-ins to make sure that they're still receiving the care that they need without having the burden of traveling. We've also launched a public-private partnership with a hospital in a remote part of Zambia where we are providing Zoom-based consultations to their patients rather than having them have to travel about 12 hours to Lusaka. We're currently looking into developing a tele-EEG service where we will have EEG machines placed in the provincial hospitals and train EEG technicians to be able to perform the studies. And then we will have an EEG reading center at our hospital in Lusaka and provide reports remotely for the studies done in other hospitals. And I recently received an NIH grant to develop a low resource stroke center in order to adopt evidence-based practices from high income settings, adapt them to our low resource setting, and see if we can improve on those stroke outcomes we highlighted earlier. As far as training innovations, one of the silver linings of our COVID experience has been that, like many training programs in the US, we moved our didactic program online and began holding our didactics on Zoom. This had several benefits. One is that the program was no longer reliant just on me or just on our graduates to provide all the lectures. We were able to access international experts in the topics that we wanted to learn about to Zoom in and provide those lectures as well. And many of the Hopkins faculty have stepped up to provide those lectures. So not only did it allow us a greater access to speakers, but it also allowed us to offer our curriculum to a greater number of people. So when we started offering our lectures online, we realized that there were internal medicine residents at hospitals across the country who could join. And there were medical students whose classes were canceled that were looking for things to do who could join. And then after we started getting learners from across Zambia, we realized that there may be learners in other countries in the region that wanted to join. And so we just started informally inviting people through social media apps and WhatsApp groups and started getting learners joining us from Nigeria and Ghana and Kenya and Tanzania and Zimbabwe. And we've really developed some great partnerships, and our curriculum has started to reach out across the region. We're currently in discussions with the African Academy of Neurology to formalize this and really make this widely available to neurologists, trainees, or just people interested in neurology from across sub-Saharan Africa. We also piloted and studied and confirmed the validity of using videotape to observe structured clinical exams as assessments in our program. We're currently undertaking a formal program evaluation to identify the strengths and weaknesses of our program, and we're working on revamping the medical student neurology curriculum at the University of Zambia as well. As I mentioned, we've been very active in research, and so we currently have ongoing research study in a variety of topics, including stroke, multiple sclerosis, neurosyphilis, lumbar puncture stigma, neurocysticercosis, neuropalliative care, epilepsy, Parkinson's disease, and dementia. And I think it's worthwhile to say that this, while this has certainly benefited the people of Zambia and the hospital and university where I've been working, there have also been reciprocal benefits at Johns Hopkins as well. So the first is that there's been opportunities for students, residents, and fellows to obtain clinical training in Zambia and to obtain exposure to tropical neurological disease, or the opportunity to really think about their clinical skills and how to apply them to take care of patients when you don't have lots of tests to rely on. So again, pre-COVID, this was a lot more common, but we had 3 Hopkins neurology residents come spend a month with me here in Zambia, learning from our trainees and from the patients. And then we've been able to start a new Global Neurology Fellowship. So this is a 1-year postgraduate fellowship focused on learning how to take care of patients and to contribute to the education of physicians in Zambia, in a low and middle income country. Dominique Martel, pictured here, is our first Global Neurology Fellow. And this is really a one-of-a-kind program. There are no other programs like this in the US right now. And then we've also been able to take advantage of Zoom again to provide remote learning opportunities for the entire Hopkins neurology residency. So I actually Zoom in. You can see me here on the TV screen in the resident workroom at Hopkins. Twice a month, I Zoom in and present a case from Zambia to the Hopkins residents and have them think through how the approach to investigating the patient and diagnosing the patient and treating the patient would be different in Zambia compared to what they're used to at Hopkins. One of the residents who graduated last year, Andrew Agostini, actually undertook an evaluation of our Global Neurology morning reports, and this was recently accepted as a publication in Neurology as well. And then at a faculty level, we've seen a lot of faculty engagement, partnerships, and collaborations form as well. So Dr. R.G. Hillis has now made several visits to Zambia where she's helped teach our residents and has functioned as a visiting attending on our inpatient service. Dr. Victor Arrudia, who's the director of the Hopkins Stroke Center, has come and done a consultation visit here at our hospital to help us think through how we're going to develop this low resource stroke center. And he continues to be a mentor and resource to me as we undertake that project. And then here you see Dr. Eva Ritzel on the right. She's an epileptologist at Hopkins, and she actually initially came to Zambia for a month and did a lot of EEG teaching with our residents. And then since returning now, gosh, that was almost 2 years ago, it was pre-COVID when she came, she has led a weekly EEG teaching seminar with our program, and Emily Johnson has joined her in that. And so the two of them, as well as one of the epilepsy fellows who graduated last year and is now at the University of Colorado, and a current epilepsy fellow, all help with that program. And then we've also had a lot of successful research collaborations built. So there have been students who've received student grants to come work in Zambia. Rebecca DiBiase was a Hopkins medical student who studied the videotaped structured clinical examination, and this was again published in Neurology. Melissa Alafros was a Hopkins resident who graduated a couple of years ago, and she received NIH R25 funding to come look at meningitis care in Zambia. And then Mona Behuth, who's an assistant professor in the stroke division, was able to get an R21 to help us look at the association between hydration status and outcomes in patients with stroke. So this has been a very brief whirlwind tour of the work that I've been doing here in Zambia for the last 4 years. And I have many, many, many people to acknowledge, a fantastic team of mentors at Hopkins and across the country, collaborations with other US faculty who are working in Zambia, but most notably the trainees and colleagues in our neurology program and our colleagues at the University of Zambia as well. And then I have a lot of people to thank. I should start by thanking Dr. MacArthur for being so supportive of this very atypical career pathway. But there's been a lot of funders who've really helped to make this possible as well. And so with that, I'll leave you with this picture of beautiful Victoria Falls, which is on the southern border of Zambia. And I'm happy to take any questions, and also please feel free to reach out via email if you have further questions after today. So thank you so much.
Thank you so much, Dr. Saylor. That was really, really interesting. I do have a few questions. This question's a bit long and has multiple facets, but could you tell us a little bit about the structure of your program? Where does the funding come from? How long is your personal deployment expected to last? And what are the steps in addition to training local clinicians to ensure the sustainability of this initiative?
Great. So those are all fantastic questions. So the funding of the program, the Ministry of Health provides the salary support for all of our trainees. So they are supporting the program in that way. My funding, the first 2 years that I was here, came from a Fulbright Fellowship from the US State Department, and then now has been pieced together through various research grants and philanthropic donations as well. My personal deployment, I just received a KO1 from the NIH to develop the stroke center here. And so that will be a 5-year grant. And we anticipate that we'll be here in country for most of the duration of that. So probably another 5 years. But I mentioned that, now that we have graduates from the program and we have, local Zambian neurologists, they have really stepped up as they've continued to do from when we first started, and are taking more and more more leadership of the program. And so from a sustainability perspective, I always tell them that my goal is to make myself obsolete, and that my goal is to continue to mentor them into becoming leaders of the program, leaders of the research programs that we have, continue to mentor them in developing their teaching and skills as well. And so I anticipate that over the next 2 to 3 years max, they'll really be the ones completely running the program, and I'll just be here in a supportive role.
That's great. What are the key lessons that you learned from this experience that you would highlight for other countries who would like to implement similar programs?
Oh, that's a good question. So I think I've learned that it's a lot of work, and it's really hard for one person to do. And I was really privileged to have grant support and the ability to really focus on doing this. And so I think that the first thing is that there has to be some minimal quorum of people that are dedicated to this. And I think one of the reasons I'm really excited about working with the African Academy of Neurology to formalize our curriculum and making it available throughout the continent is I hope that that enables other countries to begin to start training programs. So when if you are the only neurologist in a country and you're thinking about starting a training program, and you're thinking that you have to continue to see all the patients you've been seeing, and certainly you can train people while you're seeing those patients, right? The clinical bedside teaching should be taken care of. They can come along and learn from you as you see those patients. But if you're also then responsible for developing a lecture Monday through Friday to teach them the didactic parts that they need, and administering the program and developing tests and grading those tests and all of that, well, that becomes overwhelming really quickly. And so my hope is that if we can make our curriculum available virtually, that we can take over that didactic part. And then if there's only 1 or 2 neurologists in a country, they can utilize that didactic curriculum for their training program and focus on the bedside and clinical teaching. And suddenly that becomes more feasible. And so I think what I've learned is that you definitely need a team to do this. Having a team now that we have graduates has certainly made it a lot more fun and a lot more feasible. And so, but I am hopeful that we can use some of these, virtual tools that we didn't really appreciate before COVID to make this more feasible for countries with fewer neurologists to begin training in country as well.
Okay, I'm getting a lot more questions, which is great. Did you think language barrier was a problem anytime that you've been there?
Great question. So the official language of Zambia is actually English. And so everyone, all of the trainees in our program, all of our physician colleagues, our nurse colleagues, all speak very fluent English. And so professionally, there's not a language barrier. However, for people who've not gone as far in school, they may only speak their local dialects. And there are actually 77, I believe, different local dialects within Zambia. So language barriers can occur. They certainly occur for me, but they even occur for our Zambian trainees who obviously don't know all 77 languages as well. We're able to get around that pretty easily. We don't have a formal translator service like we do at Hopkins, but we're able to use informal translators. There's usually a nurse or another doctor who speaks the dialect who can come translate for us. So it hasn't been a major limitation.
Where do you see this program 5 years from now? And when do you think it will be self-perpetuating and self-sufficient?
Yeah, so like I mentioned, I really think that in the next, I honestly believe that if I had to pick up and leave tomorrow, the program would be fine already. Our group of graduates is incredibly dedicated and capable. And so I think that honestly, it could be self-sustaining now. I think the benefit of me being here for a few more years is really in mentorship, and mentorship, not so much in the clinical aspects of neurology, but as far as in faculty development and research career development and those sorts of things. So, I'm really not worried about the sustainability of the program. Where I see the program 5 years from now, I really see Zambia as being a regional center of excellence for neurology. I mean, we have really excellent clinical neurologists. We're starting to get applicants from other countries that don't have neurology training program that want to come train. So applicants from Zimbabwe and Malawi and Uganda who want to come train with us and then go back to their home countries. And so I see our program starting to serve as a regional training center as well. And then we're already starting to build really important collaborations, both internationally as well as with other regional collaborations with other countries within sub-Saharan Africa, as far as tackling really pressing research questions as well. And so I expect as our graduates continue to get more research experience, that this will become a research center of excellence and will be driving the research agenda for neurology in sub-Saharan Africa forward as well.
Great. What are the regulatory requirements, for example, IRB, to perform research in Zambia?
Great question. So we have extra regulatory requirements because of my affiliation with Hopkins. So anything that I'm involved in has to go through a Hopkins IRB, just like research that I would be doing in the US would do. But then there's also local Zambian IRBs who do a similar, similar process to what an IRB in the US would do. So they do a review. And then once you get a Zambian IRB to approve your proposal, there's then a national oversight as well called the National Health Research Authority, who then also reviews and ensures that everything seems kosher. And they also ensure that there is local dissemination before there's international dissemination, to ensure that there's really not sort of international parachute research happening, and that the benefits of the research are really being spread locally as well. So we have at least 3 levels of oversight in all the research that we're doing.
Great. In what specific ways does what you learn in Zambia benefit patient care in the US?
Great. So you can ask the Hopkins residents. I come back once a year and attend on the inpatient service for a month, and I'm constantly asking them why they're ordering so many tests. I think that because we have so many things available to us, we often go into automatic, check mode when we're ordering tests, and order things for really no reason, or for conditions that are very, very unlikely. And so I'm usually trying to teach the residents at Hopkins to really think through the utility of the tests that they want to order, the resources that they want to utilize, and to do things in sort of a stepwise approach where we test for the things that are most likely first. And then if those don't come back abnormal, then we start generating wider and wider panels of tests rather than doing everything all at once. And so I think that it does impact sort of cost-effective care and resource utilization in the US, which is a problem as well. And I think that I am certainly a much better neurologist now than I was 4 years ago, because I've been forced to really think about to utilize my clinical skills. Often at Hopkins, by the time you're called to see a patient, there's already been a CT scan and an MRI done, and you have lab results back. And so you see the patient's brain before you see the patient, right? And here that never happens. And so you're really having to use your history, your exam, to figure out what you think is going on. And then again, patients are paying out of pocket for every single thing that you order. And so really thinking through whether a test is needed and whether it's going to change your management are important skills as well. And so I think that all helps me to take better care of patients in the US as well.
Great. And I just want to say we have a lot of people thanking you for your presentation, saying how interesting it was. Lots of people saying that they are aspiring global neurologists and have been really motivated by your talk. So just want to say that before I move on to more questions. How did you manage to study the patterns of drug resistance, especially in tuberculosis and HIV, with little available data?
Yeah, I'm not sure that we've tackled that question at this point. In general, we don't have a lot of multi-drug resistant TB in Zambia. It's quite uncommon, and we generally make that diagnosis once patients fail standard TB treatment. So that is certainly something that we don't have a lot of resources to do. The same with HIV. In the US, when you're starting someone with HIV on an antiretroviral therapy regimen, you're able to genotype the HIV infection that they have and figure out which medications are going to work best for that particular strain of HIV. We don't have the possibility of doing that here. So there's standard first line, second line, and third line regimens. So everyone gets started on the same first line regimen. And if they fail that, then you move to second line and so on and so forth. And so those are luxuries we don't have and information we just don't have when we're caring for patients.
What was your biggest challenge as a neurologist in a low resource setting? I know you talked about this a little bit, but if you could just name one.
I think my biggest challenge was myself in some ways. Having done all of my training, so I did medical school at Hopkins, residency at Hopkins, fellowship at Hopkins, and we're so privileged to have access to every type of investigation that you can think of. And so I often tell people that when you're practicing at Hopkins, you rarely proceed in uncertainty. You just have so many options available to you that you can keep testing and keep going until you get a definitive diagnosis. And here in Zambia, I say we rarely proceed in certainty. It's very difficult many times to get a definitive diagnosis. And so the way we deal with that is that we figure out what our most likely diagnosis is. We try to eliminate whatever we can with the testing that's available from our diagnostic possibilities. And then eventually we get to the point where we have to proceed. And so we start treating empirically. We guess what we think is happening and start treatment. And then we have to monitor that patient closely to see if they're improving the way we expect. And if they're not, then we have to reconsider our diagnosis and try a different pathway. And so it's a very different style of practicing. And I think that it makes people really uncomfortable. It made me really uncomfortable for, the first year that I was here. But eventually, as you get more used to practicing like that and to the types of patients that you see and the disorders that you see and start to recognize clinical patterns, you get more comfortable in that and realize that you're able to help a lot of patients, even without a definitive diagnosis.
Can you comment on the availability of medications for common disease states like aspirin, blood pressure medicine, seizure medicine?
Yeah, that's a challenge for us. We usually have aspirin at the hospital. I should mention, let me just back up by saying that there are basically two parallel healthcare systems in Zambia. So there's the government funded public system where there's very little, most things do not have a significant cost, but we also don't have most things. And then there's the private care system, and you can get any medication that you can get in the US, you can get in the private pharmacies in Zambia, but the patients that we care for just don't have the resources to access those medications. So at our public hospital, we usually have aspirin, but there are times when we don't, and we have to write prescriptions and ask patients to try to find the resources to go to a private pharmacy and buy aspirin. Our seizure medicines, we only have two in the public sector. So we have carbamazepine and phenobarbital, which are very uncommonly used in the US at this point. These are older seizure medicines. And even those we often run out of, or we run out of one and have to switch to the other one. We usually have steroids, but not always. And we usually don't have the high dose steroids that we use for a lot of inflammatory neurological conditions. So in blood pressure medicines, we usually have something available in the hospital, but it often changes from week to week what is available. And patients who require more than one will often have to go into the private sector to buy the second one that they need. So it's a little bit like practicing with one hand tied behind your back all the time. But again, we're able to make a big difference for a lot of people despite those limitations.
I'm going to combine two questions, both from people who hope to do a future Global Neurology Fellowship. So what are some things I should be doing in residency that would help me better prepare me for a fellowship like yours? And also, are there opportunities to pursue this for neurology residents in the US, like a global health elective experience during residency to come there?
Sure. So as far as what you can do to prepare for a career in global neurology, I think it's just strengthen your clinical skills as much as possible. You know, really spend time on your exam, on your clinical reasoning and your clinical training. And think critically about the tests that you're ordering and the results that you're getting. I think getting basic EEG skills and basic EMG skills, because you don't have the luxury of relying on specialists. You may be the only person in that setting. So just really, really strengthening your clinical skills, I think, is really important. And then I do think that an elective to a low resource setting to start seeing what that's like and if that's really something that you're interested in is important. And so for the second question, at least pre-COVID, we did offer clinical electives to neurology residents at any institution in the US. So the year before COVID, we had residents from 14 different institutions actually come spend time with us. And so we are now open again for visitors. We have our first visitor visiting resident from one of the Harvard programs arrived 2 weeks ago, and she's our first visitor since March of 2020. But there's a lot of restrictions on behalf of US institutions still about whether or not they're letting people travel internationally. So definitely, if you're interested in coming to Zambia, please shoot me an email and we can figure out the logistics of an elective here.
Great. What is your number one priority that needs funding in the coming year?
Oh, geez.
Not to put you on the spot.
How to, yeah, how to prioritize. You know, I think the Stroke Center, we have a lot of funding to do the research part of it, but there are going to be little investments in things that will make that more effective. So a really simple example, one of the main causes of mortality in our stroke patients is because they develop aspiration pneumonia. So their swallowing muscles are weak, and instead of swallowing into their stomach, they swallow into their lungs, and that can make you very, very ill. And one of the very simple ways to prevent that is to elevate the head of the bed so that patients are never lying flat. Well, none of our hospital beds actually elevate. And so just something as simple as being able to have wooden wedges made that we could put behind the head of the bed and hospital beds for our stroke patients to elevate them would really help. Or we've talked about getting a TV that we could put on the wall and play stroke education videos and caregiver training videos for how to help caregivers mobilize their patients and things like that, since we don't have many physical therapists. And so little investments to help us have the physical resources to optimize the stroke center, I think would be helpful. And then the other thing that we're always looking for are people to help sponsor our graduates and our trainees to go to international conferences. So they do this incredible work, it gets accepted for presentation, and then all of a sudden we have, you know, $3,000 or $4,000 or $5,000 in costs to get them to the conference, get in a hotel, register for the conference and all of that. And we've had to not send people because we didn't have the funds for that. So that's another opportunity to really help support the development of our junior faculty and trainees as well.
Okay, we have 2 more questions. Thank you so much for spending all this time with us today.
Yeah.
Lots of questions. Can you expand more on your relationship with the Ministry of Health or local government institutions and any challenges in getting buy-in or engagement, and any work on underlying policy issues related to neurological conditions like management of NCDs and stroke risk factors, stigma and epilepsy, health system strengthening? And then you already talked about medications, but access to medication.
Yeah.
That's a big question.
Yeah, there's a lot of things we could be doing. So we have a great relationship with the Ministry of Health. As I mentioned, they are sponsoring the salaries of all of our trainees, and the hospital where we're working is a Ministry of Health funded hospital, and they're quite happy with the training program and the services that we're developing. And so they've been very supportive in trying to facilitate anything that we need, and they're especially keen on the stroke center that we want to develop, and are excited to support that in any way that we can, or that they can, although financial resources to put behind it will probably be limited. So, I think they've been a great partner. And I think that these past few years, we've really been focusing on training our neurologists really well. And now that we have this growing group of really well-trained neurologists, we're starting to look at how do we advocate for getting more epilepsy drugs on the national formulary? How do we advocate for Parkinson's drugs? How do we start to generate those relationships with the policy side of the ministry? So that's not something we've undertaken to a great deal so far, but it's definitely a priority now that we have the inpatient service and the training program up and running, and really trying to think of the next steps at impacting care at the next level, which I think is at the policy level.
Okay, great. And the last question, do you foresee evidence-based management and protocol-based management being possible in the near future in Zambia and other similar countries?
I hope so, because that's what we're trying to do at the Stroke Center. I mean, that's really going to be our first attempt at taking evidence-based management from high-income settings, trying to adapt it to what's possible in our setting, implement it, and see if we can show that it has an impact, which we think it will. But there's going to be challenges, right? Because that implementation doesn't just rely on us as neurologists. It relies on a whole fleet of nurses who are not going to be getting any extra money or any other kind of financial incentive to do more work. And so we're trying to think creatively about the motivations that we can provide to help with the implementation. And so my answer is I hope so. And I think in the next 2 to 3 years, it will become very apparent whether it is or not, but I'm optimistic that we can do it.
Great. Well, thank you so much again for spending time with us today. I'm going to hand back over the microphone to Jamie to thank everyone for joining us.
Thank you so much. As you can see, my dog really enjoyed it also. Love working from home. So thank you so much. It was really great to have you here today. And we're also thankful for our wonderful audience. You'll get a follow-up email that will include a recording of this program and some resources. And we're so happy to have such an active, engaged audience. So with that, I hope you have a wonderful rest of your day. Stay safe, stay healthy, and we will see you again soon. Thank you so much. Bye-bye.